Hi, this is Giuseppe Argenziano from Naples, Italy, and today, finally, I'm very happy to share with you the results of our meta-analysis on pediatric melanoma. This was a very long study because we had to screen more than 250 articles collecting about 1,000 cases of pediatric melanoma in a age range of between 0 and 18 years. Median age was 12 years, and the median Breslov thickness of those melanomas was 2.3 millimeter. As you know very well, pediatric melanoma is an extremely rare disease, especially in below the age of 10, so in prepubertal small children. And as you know very well, also in pediatric melanoma, we have two main types of melanoma. So we have congenital associated melanoma associated to congenital nevus, like in the case you can see here, and de novo melanoma, as you can see an example here. And very often de novo melanoma is showing schizoid features from a histopathologic point of view in pediatric cases. There are fundamentally two big news that I wanted to report. The first one is that comparing to melanomas in adult patients, in which we have the great majority, 70%, developing de novo or normal skin, and only 30% developing in association with a pre-existing nevus. In pediatric patients, melanoma is much more often developing in association within a pre-existing congenital nevus, 40% overall of our cases. And if we speak about small children of 10 years old or younger, the amount of nevus-associated melanoma reaches almost 50%. So off and off. Between de novo and nevus-associated melanoma. So this was the first big news. The big news. The second big news is concerning mortality. Mortality of pediatric melanoma is relatively high, but as you can see here from this graph, you can see that basically most of children dying for melanoma are dying for nodular melanoma, much less for superficial spreading melanoma, and much less concerning schizoid melanoma. So it looks like that if a lesion is called nodular melanoma as compared to schizoid melanoma, compared to those called schizoid melanoma with similar thickness, those having lesions called nodular melanoma are real melanomas. So the patients are dying much more than for schizoid melanoma. What does it mean? It means that at least a proportion of those lesions called schizoid melanoma, most probably they are not. They are only very ugly looking spitz nevi. This is the only reason able to explain the difference in terms of mortality. And also, this is also additionally proven by this other graph, in which you can see that the great majority of the mortality is concerning nevus-associated melanomas, so melanomas associated especially with congenital nevi. So patients with de novo melanomas are dying less. What does it mean? It means that those melanomas developing into congenital nevi are real melanomas, and that's why patients are dying from time to time, while de novo melanomas, at least a proportion of them, are not real melanomas, are ugly nevi again, because this is the only possible explanation why, with similar thickness, de novo melanomas are less aggressive than melanomas associated to congenital nevi. So overall, in summary, based on this data, we could describe at least 3 patterns of primary cutaneous melanoma arising in pediatric patients. And the first is this classical superficial spreading melanoma. So it's a melanoma which is mainly arising after the age of 10 years, sometimes associated to an acquired nevus and showing a biological behavior similar to melanomas of adulthood. So basically, melanomas affecting patients after puberty are behaving the same way as in adult patients. Okay. The second type of melanoma, of pediatric melanoma, regards nodular melanoma, frequently arising in association to a congenital nevus, 33% of them in the early childhood, and harboring ab initio a more aggressive behavior. And the third and final pattern includes schizoid melanomas, mainly arising as de novo melanoma and harboring higher Breslau's thickness and more propensity to nodal involvement, however, showing a more indolent biological behavior and a better prognosis. Whether the latter subtype represents a true category of biologically more indolent melanomas or a pot of mixed benign and malignant melanocystic tumors remains to be fully elucidated, but I'm pretty convinced that the second option is the right one. And with this, I thank you for your attention.